Hello, good morning. This is a presentation about migraine, which is such a common, important, and useful subject to understand from a practical point of view. Everyone has some experience of migraine, and you will all have substantial private personal knowledge of this. I would attempt now to collect together various articles, research data, and practical data from the NHS formulary to collate together so that we will have a clearer understanding of what migraine is and how best to manage it. So here is a slide which I'm now going to share. Hopefully you'll be able to view it properly. And so by looking at it, you'd be able to put in various questions if you are in the audience, and send me an email if you are looking at a recorded version. And so in general, no one knows what migraine is, but research of cerebral blood flow, oxygenation, and chemical evaluation suggests that it is the after effect of disturbed cerebral blood flow, and that serotonin has a major part to play. And so we can describe migraine as a form of headache, and it usually occurs at nights, wakes people up, affects younger people, such as in their teens, people who are expecting their periods or are ready to start a new pack of oral contraceptive pill. It is usually not minor. Otherwise, people would have self-treated themselves with headache relieving pills. It is usually moderate or severe and disabling. People have described it as one-sided or both-sided, of a pulsating nature, of a throbbing nature, but common observation suggests that it lasts between 4 to 72 hours. It is bad enough to cause functional disability temporarily, and it may occur with an aura or without an aura. It may be associated with photophonophobia and nausea. And remembering the definition, one understands migraine to follow a set pattern, but it doesn't. Some people's migraine has a prolonged aura, some have a short aura, some have no aura at all. And of course, some of the variants of migraine are very similar to attacks of transient ischemic disorders. And therefore, an urgency is exercised if there are atypical symptoms. In this context, I need to mention that in the UK alone, there is a big financial burden from management of migraine, and as many as 15% of adult females, mainly young teenage group, suffer from migraine sometimes in their lives, and that more women, to the tune of 3 times, suffer from migraine than male counterparts. There are 2 kinds of migraines: a migraine which occurs for less than 15 days in a month, and then it doesn't occur anymore for several months. And this is referred to as episodic migraine, or migraine which follows the same pattern but comes over every month for at least 3 months. And that distinguishes chronic migraine. And to know about migraines is important because that it is on that treatment or suppression or prevention are based. So what is an aura? Aura is a preliminary warning symptomatology which occurs after 5 minutes of cerebral circulation dysfunction, and it may go on to 60 minutes. It may either resolve completely or turn into migraine. And we have already mentioned about the various symptoms of migraine. Of course, we have talked about migraine, which affects the brain and the head. But of course, migraine can affect other parts of the body as well, such as abdominal viscera, the neck, and the upper part of the spinal region. The aura may be visual, such as lines in front of eyesight, flickering lights. There may be partial loss of vision, and remembering how similar some of the symptoms of migraine are to transient ischemic attacks, one should bear in mind the possibility of amyurosis fugax, a short-lived condition with cessation of arterial circulation in the retinal artery. And of course, it might be a prelude to a TIA or a stroke in evolution. There could be sensory symptoms in respect of touch, smell, taste, or feeling of insects crawling over the body, or pins and needles in various parts of the periphery. There could be dysphagia, there could be aphasia, and also various other disturbances of speech, both written as well as spoken. There are occasions when aura, as I had mentioned earlier, may result in more substantive and dangerous symptoms, such as affecting balance, affecting conscious level, and producing double vision. And when aura includes this, one would be hesitant to call this an aura, and one would respond as one would respond with the alarming preliminary symptoms of transient ischemic attack. So therefore, it is important to give substantial importance to aura, because it is at this stage that many of the attacks of migraines can be prevented. Not all, of course. Going further, what does one do? So you take a headache history, refer to the patient's diary, their memory, feedback from those who are close to the patient by way of having observed their attacks of migraine. So number of headaches, times of headache, diurnal variation is important in the diagnosis of migraine. Early morning headache is common with space occupying lesions of the brain. Character of the migraine attack. Pulsating, throbbing attack is usually characteristic of cluster headaches or vascular migraine, that is migraine with vasomotor symptoms, such as those of menopause and so on. One should know if the patient has recognized a trigger, such as obnoxious loud sound, music, or smell of cooking. And of course, how they have responded in the past to their own over-the-counter medication, such as paracetamol, ibuprofen, and what their headache health has been between attacks. So history is important. And once someone has taken a history of patients returning with migraine attacks or being referred for migraine evaluation, you become accustomed to a kind of a templated exercise. And all of this information is fairly important. I propose all doctors to be conversant with a 10-minute neurological examination. And this technique comes with experience. It's not an elaborate examination, and considering that it is completed within 10 minutes, one can appreciate its practical use. And if you wish to remind yourself of such an examination, the best thing is to Google BMJ learning and find 10-minute neurological examination. Pulse, NHS literature, clinical knowledge summaries, and many other sources of information provide you with a video of how to undertake a 10-minute satisfactory neurological examination. In addition, you need to look for obvious comorbidities and also for various triggers such as fever, rash, as would be prevalent with trigeminal neuralgia or shingles, blood pressure, visual acuity, mainly because both dropped and risen blood pressure may contribute to headache or to migraine. Tenderness in the temporal region is characteristic of GCA, and similarly, tenderness of the eyeball is also suggestive of intraocular lesions or shingles. And in some cases, even in children, there are developmental problems such as learning disabilities, anger issues, and so on and so forth. A good assessment includes undertaking usual screening blood tests such as full blood count, CRP, thyroid function tests, urea and electrolyte, and major parameters of liver functions. A routine resting ECG is helpful in conditions associated with atrial conditions such as atrial fibrillation, ventricular ectopics, which produce momentary loss of consciousness in addition to producing dizziness or headache. MRI is usually reserved for being ordered by a neurologist. It is not very pertinent for the first line physician to undertake MRI because we'll all be concentrating on the MRI findings rather than the more important clinical evaluation. So, moving on from history and examination, we now eliminate various kinds of conditions which mimic migraine. Starting from 11 o'clock position, we are all familiar with features of sinusitis, which is congestion behind the eyeballs and on the cheek, association of flu-like illness, and sometimes Eustachian disorders such as imbalance of body and also hearing disorder. And of course, a risen temperature preceding respiratory symptoms like cough or runny nose will indicate this diagnosis. Meningitis, in the absence of a child without appropriate vaccination, a prior history of flu-like illness, atypical rash on the body, stiffness of the body, loss of consciousness or alteration of conscious level, and features of meningism, which is difficulty of flexing the neck, and that also the Kernick's sign may be strongly positive. Meningitis should be treated first and investigated later. The same applies to encephalitis, and the incidence of encephalitis has sharply declined, as has the incidence of meningitis as well, because of immunization enforcement. However, encephalitis can be produced through viruses and bacteria, and one must bear in mind the association of loss of consciousness, confusion, papilledema, and also risen white cell counts. And in the end, I think one would need to resort to a CSF study. Subarachnoid hemorrhage is characterized by a thunderclap headache with no preceding aura, no preceding headache, a sudden sharp global headache which incapacitates the patient within a few seconds and may last for a short period or may remain as a residual milder feature. And of course, there are features of meningism, there are features of encephalitis, and of course, you may be able to ascertain a source, and the patient may be an arteriopath, and by association, you might suspect an anterior communicating artery aneurysm in the brain. Trauma is a significant cause of migraine, but it does not produce immediate symptoms. Trauma could be cervicogenic, and it could be related to post-traumatic injuries of the brain substance itself. But trauma relates to various kinds of PTSD, and it's sometimes difficult to relate the traumatic event to causing subsequent migraine-like attacks, and one would have to exclude trauma and then continue with the management of migraine. Viral conditions are all too obvious, and we have already talked about it in a way. And as the slide would suggest, there is more to come. And so it could be a cluster headache, which is associated with vasomotor symptoms, flushing, hot sweating, moderately severe pains, which comes on particularly in sleep, early morning, or when a patient is premenstrual. There is well-known post-coital migraine as well, and it's a fairly common and much less reported event, and it should be treated in the same lines as migraine. Trigeminal neuralgia has become fairly rare in the UK. You see it usually in the context of elderly, immunocompromised people who have not received their shingles vaccine and having shingles of the trigeminal nerve, in which case they will have a triradiate spread of symptoms and rash, and the major emphasis is in protection of the cornea and the eye, and people have turned blind as a result of trigeminal neuralgia. It is an incapacitating symptom for some, and of course, all of the three branches, which is the mandibular, the maxillary, and ophthalmic branch can be affected. Generally, as it is in the nature of shingles virus, the zoster virus travels along one path. It does not find alternative paths. So therefore, it will follow the same nerve right to its terminal branches. Dentists have encountered it because of absence of any intraoral pathology, whilst patient complaining of mastications or tasting of cold or hot substances like hot drinks. Glaucoma is also something which is encountered in the differential diagnosis, and of course, tough and risen intraocular pressure, vomiting, retroorbital headaches, and sometimes vasomotor symptoms which are typical of cluster headache, can also cause this. Giant cell arthritis can produce headache or migraine, usually unilateral on the temporal aspect with scalp tenderness all along the superficial temporal nerve. And so it could be scattered, it could be interrupted. So one part of the nerve produces symptoms followed by a skip lesion and then another part also producing it. Tension headache is like a band-like headache or migraine, and it is mainly related to stress, worries, depression, anxiety, and environmental triggers such as background loud noise, flashes of light, watching television for too long a time. And of course, there are other conditions you need to keep in mind, such as cervicogenic headaches, cervicogenic migraine, and these relate to road traffic accidents, and there is some litigation involved with whiplash injury of the cervical spine following an injury and leading on to intermittent migraine-like symptoms. An important aspect to bear in mind is medication abuse headache. So when people are taking paracetamol or ibuprofen, their serotonin level adjusts to the medication, but there is an increasing demand over time. Ultimately, even taking a higher dose of the same analgesic will reproduce or worsen the existing attack of migraine. We have briefly talked about increased intracranial pressure, which would be a feature of subarachnoid hemorrhage, meningitis, and encephalitis, and that would be characterized by papilledema and positive Kernick sign and mental disturbances and variations or loss of consciousness. Paget's disease can cause local scalp headache or migraine, and because of its vascularity, it can have skip lesions and can affect various parts of the scalp. And going on finally, to how does one manage the attack of migraine? Obviously, I had mentioned earlier that almost all of the doctors are wisely, adequately conversant with the management of an attack. So I'm not going to mention about something unique or different. It's just something that a large number of doctors undertake. So the current management of diagnosed second attack or further attacks of migraine will mean that patients would be given triptan of various kinds. And of course, use of triptan should be reserved for when there is an onset of headache, and therefore it is not much use if taken in the phase of aura, and it should be taken at the earliest part of the headache developing following an aura. And this use of triptan is reported to stop between 70 to 85% of patients with headache and with migraines. Some people have nausea and or vomiting, and therefore the nasal or the rectal varieties can work. There are many kinds of triptan, and rizatriptan, erytriptan, elatriptan, and so on. So one should familiarize oneself with the risk and benefits of one kind, and then using the nice guidelines, I would choose sumatriptan first. There's not much difference between the quality and efficacy of almost all triptans, but people have a preference. Non-steroidal anti-inflammatory drugs have been in practice for a very long time. And in fact, in the earlier guidance, high doses of ibuprofen was recommended. Now, of course, the hemorrhagic episodes, blood dyscrasias, and also stomach-related disorders have led us to find alternative and safer anti-inflammatory drugs such as naproxen, Voltarel, diclofenac, and so on and so forth. And of course, if the patient is successfully manageable with paracetamol, then that would be the best way forward. And in a step ladder fashion, one could increase it further to naproxen. And of course, naproxen or any anti-inflammatory drug of similar nature must not be prescribed for more than 2 weeks because of the dangers of well-known side effects, even with an associated proton pump inhibitor like omeprazole or lansoprazole. Patients who have nausea or vomiting can benefit from antiemetics such as cyclizine, bacastem, or prochlorperazine, domperidone. And of course, nasal spray for the children, rectal preparations for the elderly, bearing in mind then one must not use benzodiazepine to alleviate an attack or opioid, because firstly, it will not work. Secondly, it will be a habit-forming medication. We are nearly at the end of my discussions, and so be patient and sort of bear with me for a little while. And of course, how do you manage a chronic attack? I apologize that the slide doesn't show much. Maybe there is not much space. Try this, and even that doesn't help. So how does one manage a chronic attack? By virtue of definition, it means that the migraine has taken place a second time or more. And of course, one should ask the patient to check with their own migraine diary, take feedback from those who have observed the patient's migraine, and one should aim to control triggers which have resulted in development of aura or migraine, such as controlling psychologically, such as reducing stress at home and at work. And I have no suggestions to offer as to how to reduce stress at home. But in terms of work, reducing the VDU exposure to the screen, concentration on looking at numbers at a close distance, having poor eyesight and compensating physiologically and developing a headache or migraine can be useful. Sleep, either too much, too little, or at wrong time, can lead to development of a chronic attack. And there are other health factors such as obesity, excessive smoking, which has a direct link, drinking alcohol beyond a safe limit, not having enough water to drink. A normal amount would be 2 liters per 24 hours. A safe level of alcohol would be no more than 14 units per week. However, there are relationships described by experience, such as food and drinks containing monosodium glutamate. We also learn about various kinds of cheese, red wine, and certain bitter, astringent, and spicy materials which are enjoyed first, and then patients suffer with an attack of migraine. So when the pattern is obvious that environmental and other trigger factors have been reasonably well controlled, then it is time for medication prophylaxis. And Prophylaxis should, according to the NICE guidelines, be offered when there are 4 such attacks which are of a similar nature per month. And therefore, the proper treatment of prophylaxis is said to reduce the recurrence of migraine by almost 50%. One drug should be tried for a couple of months, even if it doesn't appear to be helping much, before it is either increased in dosage or it's supplemented with another dose or substituted for another dose. And when 2 months have passed and the patient has had good reaction or good response to it, then it should be given for a minimum of 6 months. And this is hard to apply because when patients are free of migraine, they also give up on prophylaxis and then they suffer from it much more. Repetitive attacks leave behind cumulative features, either in terms of mental health aspects or functional disability. And this is why considerable emphasis must be given to the use of a prophylactic medication. Traditionally, propranolol at the dose of 80 to 160 milligrams twice a day has been found to be fairly successful, and it is under the NICE 2012 guidelines. We can use topiramate as well as a suppressant, bearing in mind that migraine involves young female patients more often, and topiramate can be teratogenic, and therefore, with reservations, it should not always be used, and if used, should be used in the hospital settings. Gabapentin, the dose of stepping up from 200 milligram per day, going right up to 1200 milligram per day maximum. Some patients have actually benefited from Botox applied to the scalp region. And so there are many other ways of preventing migraine. This list is minimal. However, a large number of improvements have been reported by various other medication as well. And so that will be like tricyclic antidepressant, amitriptyline. It could be a result of SSRI, such as citalopram 20 milligrams per day, or venlafaxine 75 milligram once a day. So people have also claimed improvement of chronic migraine with HRT, and the Million Women study, which had looked at many aspects of women's health, has not suggested using HRT for migraine. There are alternative remedies also available, but there is much less scientific explanations of benefit, and there is no confirmation that the alternative remedies are working by virtue of their placebo effect. And so these would be acupuncture to the scalp or to the other region, massage therapy, health food, which is rich in magnesium, and the lack of magnesium is reportedly involved with the serotonin level when the cerebral blood flow is disturbed. Lack of vitamin D is also said to be related to migraine, and accordingly, there are many over-the-counter health food preparations which include magnesium as well as vitamin D supplements. Psychotherapy by way of cognitive behavior therapy does have a positive relationship with management of chronic attacks of migraine. I have no idea how it works, but reports suggest that it has a positive relationship. and that it will improve. So there would be many other ways of alternative remedies or treatment of migraine. An important thing remains as to how does a doctor say that patient X has more of migraine related functional deficit than patient Y. If they've all reported similar symptoms, it would be difficult to quantify which is worse. And that is why various parameters have been developed, such as quality of life indicators, depression scores, anxiety scores, headache function scores, and one of the more popular ones is MIDAS, which is migraine attack disability score. And so this disability assessment score has become fairly positive in its application. And one could say that two patients may have similar symptoms, but one may have more deficits of their everyday functions than the other. And so briefly, I would just put it on display. So it asks 5 questions and patients put in numbers before them, such as if we look at the first and the second example, that the first one is on how many days in the last 3 months did you miss work or school because of your headaches? Supposing the patient looking at the diary would say, oh, in the month of August 2021, I missed work by 5 days. So 5 is the score. The next question, how many days in the last 3 months was your productivity at work or school reduced by half or more because of your headaches? Do not include days you counted in question 1 where you missed work or school. So ignoring the first question, so the productivity is reduced because the line manager in the office has complained that the patient is not, the person is not attending to telephone calls or inquiries, or has not cleared their waiting tray, and that the quality of the work was reduced. So a person should realistically think back, consult with diary, speak to a colleague, and then say, list the number of days. He might say that I managed reasonably well without any deficit for the whole month, even though my migraine was affecting me at work. And so the answer might be 0. Or you might say, on some Fridays, I had this problem. So the month mean having 4 Fridays, he would say 2. So the score would be 2. So you would then add up. So the first question attracted 5. Second question maybe attracted 2. And that way you would continue to go through this list. And this is the list which the patient fills up, because the questionnaire is handed to the patient. This is migraine disability assessment score. Once the patient has done all that, then of course we apply the inference. So these are days. So between 0 to 5, little or no disability. 6 to 10, grade 2. 11 to 20, grade 3. More than 20, severe disability. So it is on this basis of such reporting that the Department of Works and Pension can indicate that a person X is severely disabled, is unfit to work, and therefore is entitled to certain benefits. The employer might agree and refer the case to an occupational health advisor, who may suggest that for the next 3 months, this patient should be working from home to reduce the stress, or home improvement could be financially supplemented by having cleaner air, or advice given for removal of pets, carpets, and various other trigger factors. So, in summary, today what we discussed is migraine, relying on the NICE guidelines, which was published in 2012 and was then reinforced in 2018. We talked about the definition of migraine, how migraine presents itself, whether or not there is an association with aura. We talked about the incidence and the prevalence and the classification of migraine between episodic and chronic migraine. We also talked about the symptoms, features, reliability, and importance of aura, and how we must distinguish it from transient ischemic attack or stroke in evolution, or amaurosis fugax, and how we can recognize it. Now, nationally, advice is advertised to all members of the public as to what to watch out for when someone is developing a stroke, such as dropped face, difficulty with speech, difficulty of movement, and then time to call 999 or the emergency services. So similar advice can be given by a doctor to their patients in respect of migraine with classical aura. We talked about how to assess a patient by virtue of patient's support, feedback from the diary and responsible family members. We talked about general examination, and in particular, to become more conversant with a 10-minute neurological examination. And I signposted PMJ online, BMJ Learning, 10-minute neurological examination, also available with Pulse, clinical knowledge summaries, and many other sort of well-regarded sources of information. We talked about doing general tests to exclude comorbidities or assess comorbidities by way of clinical assessment, routine blood examinations, and ECG. And then, of course, we said that MRI should be left in the hands of the neurologist. We also undertook a study of differential diagnosis and considered a few conditions of infection, inflammation, injury, and also impact on life. We went on further to distinguish migraine from various conditions which cause headaches. And then in the end, we went up to the management of an acute attack, and we talked about triptan, and that various varieties are available, but one is no better than another, and that step ladder process should be adopted, and that if a patient has aura, then it is more predictable that at the end of the aura, there will be migraine, and at the earliest feature of headache, one starts with triptan. Alternative to oral methods have also been available. And of course, we talked about the conventional anti-inflammatory medications, including paracetamol, and their modes of administration. We talked about then chronic attack, and we said what chronic attacks mean, and that there should be elimination of triggers with psychological and health support. We talked about prophylaxis, and we mentioned that one drug which prevents migraine attacks should be used for a minimum of 2 months. If it is good, then it goes on for 6 months. But if it isn't good, then after 2 months, one could replace it or increase the dose. And we talked about the conventional use of beta blocker and topiramate with cautionary advice about its teratogenicity. Talked about other neurological blockers such as gabapentin, pregabalin, talked about Botox, and we also talked about alternatives to these, such as tricyclic antidepressant, SSRIs, numerous non-addicting analgesia, and then we talked about alternative treatment such as acupuncture, cognitive behavior therapy, and also relaxation exercises and stress-free management of work. We then finally talked about how to evaluate and assess the degree of suffering from migraine by talking about various kinds of lifestyle scores, activity of daily living score, depression score, anxiety score, migraine suffering score. And in that respect, we talked about migraine disability assessment score, MIDAS, and that it is based on patient replying to, after reading carefully, 5 questions. And as a result of their questions, one can then assess functional impairment by this grading. So hopefully I have been able to cover some of the grounds which confuse all of us with migraine. And there is no one person who can claim to be a migraine specialist. And obviously, one will need to develop one's own strategy and develop the art of experience and reducing the pace so that you could arrive at a functional therapeutic level very quickly when dealing with the next patient of migraine. Thank you very much.